This conference will now be recorded.
Okay, the live stream has started. You're welcome to go ahead and start the committee meeting.
Great. Good evening, everyone. Thanks for joining us here tonight. We are joining at the last board meeting, we created the ad hoc telehealth committee meeting. And at that time, we talked about the members of the committee being Dr. Schottenstein, Dr. Bechtel, Dr. Soin, and Dr. Feibel. First order of business, really, Dr. Schottenstein, with your approval, we would like to add Mr. Ganadakis to the committee as well.
Yeah, please.
Great. Welcome, Mr. Ganadakis. We would also, I think we have decided Dr. Feibel is going to chair the committee for us. So thank you, Dr. Feibel, for agreeing to chair the committee.
My pleasure.
All right, so really tonight our goal is to have a lot of discussion around the House Bill 679, which is the telehealth bill. We have provided to you a draft legislative amendment to the bill with what we would like to take to the legislature to start shopping as an idea of an amendment before the bill becomes law. And then we can get into the details of all of that. But we would like, some guidance in that legislation that we've drafted for you. And then we also have a memo that Nate Smith, our legal counsel, has created for you that has some sort of guiding questions about things that we need to be considering as we do go forward on telehealth. I think that when we go to talk to the legislature about our proposed draft, if this is what we decide to go forward with, we're going to get the types of questions that are in this memo. And so we really need to know what the board's perspectives, the board members' perspectives are as we go forward and talk through this language with the legislators. And I think it gives us some good guidance as we go forward when this bill does become law. I think we've had good discussion at the board meetings to date that we all recognize the real value in telehealth and how valuable of a tool it's been during our pandemic. But I think as we shift into new norm, then what does telehealth look like and what does standard of care need to be? And what is the role of the medical board in all of that? So with that, I think the first part of the discussion really is probably best centered around the legislative draft and any thoughts you all might have about the draft or any particular part of that. And, maybe we'll tackle some of those questions in the discussion of that draft, or we can then just take the questions separately after that. And with that, I'm going to turn it over, Dr. Feibel, if you have any questions or thoughts as chair different than that approach, please.
I'm fine with that. The other option is to maybe go through Nate's memo first, if you would like, and that will frame some of the talking points maybe that the amendment has. Either way, it's fine. What would be the committee's pleasure? Any thoughts?
Sure, let's go through the memo. It's good. Yeah, memo. Agree.
Nate, you want to go through the memo for us? And frame the talking points?
Sure.
There you go.
Thank you. Well, so the memo, it does kind of tie into the draft as well. It's just, as I was working on the draft, it was questions that drafting was generating to me. And as I said in the memo, the draft is loosely based off of some teledentistry provisions that got inserted into House Bill 679 right before it was passed by the House. So that amendment, which is also another one of your attachments, was a rather lengthy amendment that gave a great amount of rulemaking and specificity to the practice of teledentistry. And so the idea was to incorporate some of the items that they were able to get into the bill sort of strategically. If they were able to get it, then we certainly have an argument that we would be just as deserving. In addition, also incorporating some things from the medical board's 2012 telemedicine position statement, and some other items looking at the FSMB telemedicine policy, but mainly the teledentistry amendment and the board's 2012 position statement. First up is the idea of the initial and annual visits, and I think this was a item that we had spoken about in policy committee. And the initial version of House Bill 679 had, I would say, a more strict that the initial and annual in-person visit, or the initial and annual had to be in person, except if the professional waived the requirement, by determining that the situation is critical and an in-person visit is not practical. The bill was then amended to what's basically if the appropriate standard of care is satisfied, which sort of begs the question, what is the appropriate standard of care and what standard should be used to determine, whether that would be, what's appropriate for an initial and an annual visit. I remember Dr. Feibel talking about it certainly could depend across specialties. So I don't know if you guys would, that's kind of teed up if you want to talk about that portion first, or.
Sure. A couple things. First off, I can't see Dr. Soin on my screen or Mr. Ganadakis. So if people have their hand raised, those two have their hand raised. I can't see it. So somebody help me out with that. I would just like to say from the start that, first of all, the memo was very good. Thank you. And well prepared. I don't really personally, I don't like either of these statements. I think they give a lot of leeway to the professional and would be exceedingly hard to enforce as a board, violators of this. So if the appropriate standard of care for an initial or annual visit respectively is satisfied, who sets that? That standard of care, I don't know what that standard of care is. I don't think most practitioners would know what that standard of care is. And so we would have to, which is down further through the rulemaking process, make what that standard of care is. But again, that's super arbitrary. So I think this is my personal opinion. And again, the only specialty that I really think falls outside of this is the psychiatry one. And I'll let Michael talk to that. But every other specialty, I think it is important to develop the doctor-patient relationship in person before you can really embark on a journey with that doctor. And I think that's a very important, saving time for a pandemic, obviously different, but without a pandemic or some other very extraordinary reason, that patient should be seen in person the first visit, and at least on a yearly basis, in my opinion. And again, psychiatry may be, there may be one other specialty that I'm not thinking of, but psychiatry may be the only visit that would be different than that. And Michael, again, you can comment about that.
My initial thought, and I want to try not to look at this just through the prism of psychiatry because that's, my default, but I sort of felt like there were two ways we could proceed in general. One way is to, as a default, support the expansion of telehealth and then insert guardrails, around specific areas of concern. And the other way would be to support, as a default, the restriction of the telehealth with specific allowed expansions, I should say. I guess my thought was that we'd be right to support the expansion of telehealth as a default. I just feel like the public would be so well served by really improving access. I think that there are a lot of people who would, even on that first appointment, have a lot of trouble coming into an office if they are out of the country and they don't have money and things like that. I think that, to your point, if there are times when the telehealth is inappropriate for an initial appointment because you would say, well, we need to have a physical exam, I think that's more than fair. And I think that's what falls under the standard of care argument. I think that ultimately we can support the increased access to care by allowing for telehealth as initial and annual appointments, with the understanding that if there are certain, professions, specialties, or types of appointments where a telemedicine appointment is just not appropriate, then, that person would be right to come into the office.
And I think that I support the expansion of telemedicine as well. I think if you were to allow the first visit as a telemedicine visit, that it must include a video interface. In other words, if you expand telemedicine to allow just phone audio only, I don't think that would be sufficient for an initial visit. So at a minimum, we need video interface to interact with that first visit. Regarding pain management, which is how I look at things, the DEA is going to have they're going to have rules, save the pandemic, of course, about requiring physical exams prior to, live physical exam prior to, writing a narcotic. And I know our chronic pain rules are going to dictate some standard of care regarding filling opioids of, say, 80 or more MED, requiring some physical exams. Because of those guardrails for pain management, I feel comfortable with it.
I agree. I think that an in-person to person visit is definitely superior to a video visit, but there may be situations in which the first visit could be a video visit. I agree that a telephone visit is just inadequate. I mean, you're not able to provide any physical examination. It's just not adequate. But to give you an example, I saw an 88-year-old woman who was very debilitated with a rash. She was physically unable to come into the office, but their family was able to provide a video visit at the bedside in which we were able to make a pretty accurate diagnosis. So she would have been not able to have any access or care at all to dermatology because she was immobile. But by using the video consult, we were able to make a really critical diagnosis that was really important for her. That would have not been possible if she had to come directly to the office. So I think there are situations where the first visit can provide a lot of access to care that otherwise wouldn't be possible.
Yeah, to Dr. Feibel's earlier point, dermatology is probably another specialty where, telehealth is very appropriate for those initial appointments. I guess my thought is, by allowing an initial assessment to be over telehealth, we're not prohibiting an in-person appointment. So I think that, doctors can use their discretion as to when something like that is going to be acceptable or not. All it does is increase the flexibility of the doctor to, have that option. It doesn't require the initial appointment to be telehealth. It just allows that as another possibility for that first appointment.
Yeah, one of the provisions in the law states that a doctor can decline to do a video visit if he feels it's not appropriate.
Mm-hmm.
Yeah, my concern, and I think we may have seen it a little bit during the pandemic, is people using this as a revenue generator and not for the purposes you have elucidated. And I realize we can't protect from every situation, but my worry is we're going to have out-of-state doctors who are going to offer their services. We're going to have in-state doctors who are going to offer their services, and from different areas of the state. Not, in other words, somebody from Cleveland is going to use a doctor from Cincinnati, or a doctor from Arizona who has a license in Ohio is going to telehealth a patient from Columbus per se, and that patient likes the convenience of it, but that patient is not getting good care. And so I think we have to guard against that in some way, shape, or form. And I think when you don't have that first visit in person, I realize there are some extenuating circumstances, and maybe we could carve those out, the ones you've mentioned, for instance. But I think people are going to abuse this system and use it for the wrong reason. I think we have to be really, really careful of that if we want Ohioans to get good medical care, because a video visit, there are very few situations that a video visit is as good as an in-person visit. Very few.
Dr. Feibel, Mike, I don't know if you can see me.
Yeah.
I want to build upon what you said, because I think Dr. Schottenstein makes an excellent point that there's nothing prohibiting a physician from seeing in person the way it's drafted or the way we're proposing it, that is. But human nature and is sometimes economics would dictate we're going to maybe, early on in the process, you'll see more discretion. But a year from now, 2 years from now, because we're changing the law, this isn't a regulation, a suggestion, a mere advisory. We're changing the law. And as we go down the road, not just on day one of its enactment, but we need to look at what the health profession is going to look like on year 5. And as a consumer member on the board, I'm really concerned because for the past 10, 11 years I've been on the board, we've had a great aversion to expanding telehealth. And I understand fully, and I appreciate fully the times we live in here in the pandemic world, but this too shall pass, Lord willing. And, we get back to normal to some degree, and do what we do now will impact the practice of medicine in Ohio post-COVID-19. So do we, we're what we do here, assuming the legislation passes, and that's another part of the conversation that we need to talk about later. But, do we want to, for the sake of convenience now and the times we're in this snapshot in our lives, do we want to blow open the practice of medicine via telehealth? And as Dr. Feibel said, way better than I ever can or could, the unintended consequences that go with that. So I appreciate science and I appreciate technology and the world we're in. It's 2020, it's not 1980, but we have to be very careful and find a very even balance in what we propose moving forward. Just my commentary to step in as a consumer.
So I guess, if I may, I guess my thought is I'm very respectful of those comments. I think those are all very, very valid. I guess my thought, though, is doctors still have a fiduciary responsibility to their patients, not to essentially abuse the practice that way just to generate income. And we still have the requirement to engage in a minimal standard of care. And we still have the requirement to document our care appropriately. I feel like we can, potentially minimize those areas of abuse by putting guardrails around them, where at the same time potentially doing a lot of good for a lot of people by increasing that access to care, which I think is a universal good. I think we'd all like to see that happen in some way.
This is Kim. I just want to remind you about your rule for prescribing to patients not seen. So that was amended a few years ago. And the way it stands now, a physician has to do an evaluation, but they can do it in a method that is appropriate for the patient and the condition that they're being seen. So that is generally interpreted to allow telemedicine to establish a patient for whom a prescription is then going to be written. And it's also used for like cross coverage and other situations like that. So it's not a true telemedicine, but I did just want to remind you about the language in that rule, and it's in your packet as well.
So could a physician, under the current law, could a physician see a patient 20 times via telehealth in a year period, having never met that patient in person, and still meet the minimal standards of care? Because I think they probably could. I don't think we could have an action against that practitioner, most likely, based on minimal standards of care, just because they saw the patient via telehealth 20 times. But that's really not the intent of what we're trying to do as physicians. If that's the case, we can have people in India seeing patients. We can have people in all over the world see our patients. And part of an appropriate interaction is a doctor-patient relationship. And being on enough Zoom calls and Zoom meetings, these meetings are not as interactive as real meetings. And I feel the same way about doctor-patient relationship. You're not seeing body language. You're not seeing the whole patient. You're seeing bits and pieces. And it's just, to me, it is not the standard of care. But we're relying on minimal standards to regulate it. But what are those minimal standards? Because I think the things I'm worried about with telehealth, and I realize it's good in very specific situations, but I don't think it's good on a come-all basis. And that's what this pandemic has opened up, because a lot of legislators and a lot of patients and a lot of physicians like the fact of this telehealth because it's easier. It's less time for the patient. They're going to enjoy it more, but it's not good medicine. And yes, it's medicine, and I did it, but I don't feel like my patients got the best care they could get. And I think you're relying on a lot of factors a lot of decision-making factors to weigh in to say a patient and a doctor are going to do the right thing, because the patient's going to like it way better in most situations. Patients don't like to come to the doctor's office, so they're going to like sitting in their house and being able to talk to the doctor or their office, not having to take time off work to go do it. The doctor's going to like it because it in some respects it's easier in a lot of respects than having that patient in the office. It's a lot less staff, that type of thing. And so I think you're going to see a lot of abuse of this. And I realize that a lot of people are clamoring for it, but I think you're going to dumb down medicine by doing it personally. And again, I'm obviously in the minority based on this conversation, and that's fine. I just worry about the citizens of Ohio and their, I appreciate their access, but I also want them to get good quality medical care. And I don't think over telemedicine they will do that.
So we've been talking about this for 20 minutes. I mean, I suppose is your proposition to mandate the first visit to be in person, and then after that they could have telemedicine visits if it's appropriate?
I would propose that, barring a very unforeseen and extreme situation. And I think Dr. Bechtel's example of that is that situation, but it would be known from the law that the expectation would be in person and the exception would be televisit, versus if we have it the other way. I think televisit is the rule and an office visit would be seen as the exception potentially to patients. So that's what I would propose, yes. But again, if I'm in minority, I'm willing to go along with, I'm willing to put forward the majority's opinion, obviously. So,
yeah, I would just point out, I think that is different than what our rule. So our own rule says now, and how it's interpreted. If we were going to, the rule says you should have an in-person visit, but it does say that there are situations, where the physician can determine that they can do their evaluation, in a remote way. And then there are a number of steps that have to be met for that to happen. This rule, though, only applies to the initial visit before prescribing. So it's not a true telemedicine rule, but I think if you mandate an initial visit in all circumstances, we'll need to make a rule change there. So I just want to point that out. And if it's in the statute, then the statute would control over the rule.
So again, I'm very respectful of Dr. Feivel's concerns. I guess I don't mind so much that a patient in Cincinnati might have a doctor from Cleveland, right? I guess I don't even mind that, a doctor who doesn't live in Ohio might see an Ohio patient as long as that doctor's licensed in Ohio, right? Because if a doctor's going to have patients here, that doctor should be licensed here. I guess to me, it's like the market, it increases access, it increases, the supply of practitioners who are available to the patients. You've got those patients, of course, where certainly it's easier if they're just at home than going into the doctor's office. But maybe that's a patient then who gets care because he has an appointment over telemedicine as opposed to a patient who doesn't get care because he doesn't go to the doctor's office. So again, I guess it's just sort of my default. I'm, of course, very respectful of however the committee wants to proceed. I guess my default is that it just gives doctors another option. It doesn't enforce telehealth for that first visit for doctors who are concerned that it's not good practice of medicine based on the nature of the case they're going to assess. They can do it in person. It's just flexibility is sort of how I see it.
Well, I think we probably should come to some resolution on it. As Dr. Sloan said, we talked about this for 20 minutes. So I will put out, or I guess we could motion that it sounds like the majority of the motion would be for that there's no need for an in-person visit.
Well, or what about the middle ground approach, where at least the first one, barring extenuating circumstances, is that a non-starter?
I'm in favor of that, but I gathered from the other two on the committee that was a non-starter. So I was just trying to put out a motion that was going to actually pass.
I support your proposal, Dr. Feibel. I'm on the committee. I think it makes it 2-2.
I think Dr.
We have 5.
We've got 5.
5 members.
There are 5? Oh, sorry. I don't see Dr. Soin. I lost Dr. Soin on my screen.
I lost Dr. Soin as well.
Dr. Bechtel, are you for Dr. Schottenstein's proposal of any telehealth visit can be anytime, any place?
I would like to see a proposal where the first visit can be a video visit, not a telephone visit, but a video visit. If the circumstances are such that it improves patient access, or there's circumstances in which a video visit would actually provide better care or access to care. Examples would be like I gave that debilitated patient that absolutely couldn't have made it into the office. I hate to have that person who actually had a potentially life-threatening rash be denied care, who could have really significant consequences. But I could also document in the medical record that care was appropriate by video visit because of the underlying medical circumstances. I'm sure what Dr. Schottenstein sees psychiatric patients in which initial video visits might be the best approach. I would like to say, Dr. Feibel, that dermatology has also the potential probably for the most abuse of this. I'm sure there'll be a lot of out-of-state dermatologists who want to promote some type of service where they, advertise for patients cash only. We've done this like in Pennsylvania, where if you have a rash, you take a picture of it, and a dermatologist somewhere will look at the picture, make a diagnosis, and prescribe medication without ever physically seeing the patient. And they charge like $75 a visit or $50 a visit, cash only. They see simply a picture; it's not video, and it's not real-time video. And again, there's no insurance. They pay $50 and get a prescription. So there's so much potential for abuse, as you pointed out. So I think having some guardrails will be really, really important.
Mm-hmm. Yeah, and just to weigh in, I support the expansion of telemedicine. I think it could be done at an initial visit. I would think you have a guardrail of the duty to maintain a minimal standards of care. If someone is abusing it and seeing, 200 patients a day, with poor documentation, that would fall below an acceptable minimal standard. And then for areas of vulnerability, like pain management or other things, there are other rules and laws that would dictate, inpatient or face-to-face visits. And if you're in a surgical specialty, I think it would be below standard of care to operate on someone if you've never laid a hand on them, and so I think that guardrails are there. I support embracing expansion of telemedicine, but I'm fine with the decision of the group.
If I may, and I won't beat a dead horse here, but Dr. Swain, immense amount of respect for you, and you said something a moment ago that caught my ear. You said, and if a physician seeing 200 people a day, is that the standard? Is that in our rule? What if it's 175? What if it's 125? What if they see 60 patients a day? I mean, telehealth is going to, we don't have any guardrails around telehealth, meaning, I mean, what's that magic number? Well, hey, that's too many. Well, is that the eye of the beholder? If a physician comes in and says, I can maintain in my practice and see 200 patients a day and meet the standard of care, how are we going? I mean, this is going to happen because physicians are small business owners. Some work in a hospital setting, of course, and they're going to find ways to maximize their profit. And if they believe they can do it and maintain that standard of care, then 200 might be a sweet spot for them.
Yeah, I suppose, that certainly is possible, and I respect that opinion. I think, anytime you do something new, there's going to be risk to it. But I think there's certainly advantages as well. But, just my opinion, so.
I also don't want to beat a dead horse, but we keep talking about guardrails around this. I'm not understanding what the guardrails are. To me, minimal standards of care effectively are no guardrails because those cases are always hard to prove with, even when people do egregious things. And so I don't know what guardrails we're going to put around this if we don't have some sort of inpatient visit. I think you're going to see doctors from Arizona, doctors from California, doctors from all over doing office visits in Ohio on patients and really exploiting Ohioans for their money. And I realize that we can't protect from all, but I don't think we are doing Ohioans a service by expanding this as openly as we are. I'm all for expansion of telemedicine as well. I just want the adequate guardrails, and to me, minimal standards is not enough of a guardrail to feel comfortable. But again, we'll go with
and for me, it's fine because literally we're just talking about the first visit, right? I mean, so visit 2, I suppose, could be telemedicine, and then someone could see 200 patients a day or 300 patients a day from Arizona on visit 2, 3, and 4. There's nothing to stop that if that's a concern. But and to that end, because it's only the first patient visit, I'm not going to sit here and argue forever over it. I mean, if you guys feel that, I'm totally fine with an inpatient visit or a face-to-face visit.
So it sounds like we have enough to go forward on, I think, to move on to the questions that the inpatient visit for the first visit, excluding extenuating circumstances such as the situation that Dr. Bechtel described, that there are going to be those situations that in person might not be possible and actually would be more risky to have in person and kind of have a perverse effect on the care. So if that's the direction that I'm hearing here, I think we're good to move on to the second question if that's what we feel comfortable landing on, that in-person visit, excluding some circumstances. Good. Okay, great. So Nate, back to you on the second question here. That was the easy question.
I think you're muted.
Nate.
Yeah, Nate, you're muted.
Or frozen.
And frozen.
It was freezing.
There he is.
Okay. We're moving to the second part of the discussion. Okay. So second is I think should be a less contentious question, which would be, should the standard of care be the same for in-person versus telehealth visits? What spurred the question in my mind, I think it's kind of a seminal question of the whole thing, but part of the legislation talks about having a different standard for civil liability. I quoted that section, and I believe it's subsection D talked about that someone could be liable in damages, and they would not be liable if it was based on the claim that they don't meet the same standard of care that would have applied for in-person services. So that spurs the question of, should the standard of care be the same for in-person versus telehealth? And the board's position statement on telemedicine, as well as, I believe,
his video keeps freezing, obviously. I think we can start on this one while his video unfreezes, maybe. My first thought on this is I think, based on our previous conversation, we certainly should hold people to the same standard of care that would apply. I think the original intent of this, in my opinion, and I actually lobbied for this as much as I could to different people in different offices, was so that the liability wouldn't be there and you wouldn't be held to the same standard of care, because you can't do the same standard of care with a visit via and most specialties via visit using telemedicine. So I think this should not be part of the legislation, and they should be held to the same liability. And that may cut down on the number of televisits that are done for inappropriate reasons, and really help. That might be a little bit of a guardrail that Michael was talking about.
That's very fair. Yeah.
Anyone else on it?
I guess, forgive me, I guess my thought is, when I first saw that, I thought that maybe that was something that was proposed because anyone, I guess, potentially could make that claim about telemedicine, and that essentially inherently it is a lower standard of care. And if inherently it's a lower standard of care, then it really potentially opens up a lot of litigation, and it potentially acts as a deterrent to the use of telemedicine, where essentially it could, really diminish the expansion of that service. So I guess that was my thought, is that it was probably included as more of a safeguard for those doctors who want to feel comfortable practicing telemedicine, not having to worry about the fact that they could potentially be liable just on the basis of performing telemedicine service per se.
So the draft that was provided to you has that provision still in there regarding the civil liability, but in terms of the amendment that's in bold under, it's actually the last bolded line, and it would be on page 5 of your PDF under 2B, or excuse me, 2A, saying services delivered by healthcare professionals licensed by the board should be under telehealth shall be consistent with their standard of care for in-person services. So that's sort of where the proposal draft of the amendment is. So it's kind of deciding both those questions, whether I think whether you believe the standard is the same is kind of the big question. And then if you do, then you have to think about that civil liability question. But I think for our purposes, probably the first question is the bigger one.
On 2A.
Yeah. So, it's entirely, I was curious about this, Nate. It's like contradictory to the statute, right? In other words, the amendment language is contradictory to paragraph E, right? Yeah.
That's correct. I based the amendment language off of what the FSMB model language was and the 2012 telemedicine position statement language. And I think brought up the liability thing as a discussion point, but obviously the board has to feel comfortable whether their position would be the same as it was in 2012.
if we adopt this language that the standard care should be the same, I think there should be a statement in there that telehealth used at the time of a governor's declaration of emergency or whatever, however that would be immune from liability for using telehealth in lieu of in-person visits.
Yeah, but do we need to say that? Because didn't they do that automatically during this pandemic? I would presume.
Yeah, I think there's already language of that nature in previous.
I thought they had to put that in there, didn't they, Stephanie or Kim? Didn't that have to be special language that was put in the order?
Yeah, there was definitely special language in the order to that effect, and so that would be required, I suppose.
I believe there's legislation floating around right now regarding civil immunity for any healthcare services delivered to the pandemic. So it would be a separate emergency law that would be superseding and governing that situation.
It's not currently law today.
I don't believe so. I believe it. My recollection was there was a few things that they had to work out in conference committee, but that the law would be retroactive from the time that the pandemic was, or that the state of emergency was declared by the governor, March 9th, thereabouts, until the end of the pandemic.
It would seem to me, if we're talking about telemedicine, which we've never really had a law on, we would put that as, because it does change the calculus of who is eligible for telemedicine based on an emergency like this, like the pandemic. I would feel comfortable doing telemedicine on a patient to save them coming into the office during the pandemic. And I wouldn't want to be held to the same standard of care and take the chance that that the legislature would make me immune during that time. I think that should be in this bill personally, if we take out the civil immunity that's in there.
But then do you think you should eliminate the first visit live in a pandemic as well, under the same logic?
Yes, I think.
Or would you mandate live visits during a pandemic?
No. I think during a pandemic, any visit is acceptable personally to save the public health of people. Again, I would hope that during a pandemic, a live visit would be the exception rather than the rule. And during a non-pandemic, a live visit would be the rule rather than the exception.
Nate, do you think, do we have to get that granular with details on pandemic regarding this bill, or what do you think the legislature would think about that?
I think presently the way it looks like that civil immunity bill is heading, that people will be covered from the pandemic. So I'm not, but to Dr. Feibel's point, we don't always know what's going to happen at the next situation, although we haven't had a situation like this, I mean the most quoted last pandemic is the Spanish flu in 1918. So, I think we're pretty safe with the present legislation.
God willing, we won't be on the medical board still when the next pandemic comes.
So I guess in answer to your question, Dr. Soin, I would say that this other piece of legislation is going to cover it in terms of the civil liability.
Yeah, so if that's the case, I agree with Dr. Feibel that they should be held to the same standard.
So Nate, the language, again, it's contradictory to the statute. So do we essentially try to put that in as amended language, or do we just try to work with the legislature to change the language they've already proposed?
So the language talking about the civil liability is just proposed language. It's not actually in law right now.
Right.
So we could amend that proposal and try to strike what's actually on the draft. It's actually been changed to subsection E. We could actually try to strike that in an effort to make it consistent with our statement that the standard of care for in-person visits should be the same as for telehealth services. So that's an option as well.
Yeah, I think as presented right now, we have the new language as presented. I don't think we tried to harmonize the rest of the bill around that new language.
Correct.
So we would, once the proposals are kind of solidified, I think we could harmonize other parts of the statute around that.
The effort was to kind of show you guys what a rulemaking for standard of care would look like, but there's obviously some more harmonization to do based on what you choose. So if you choose the standard of care being the same, then we would have to tinker with some other parts of it and bring it back to you.
All right. Well, I would make a motion just to see where we are, at least that we hold people to the same standard of care, whether it's a telehealth visit or a non-telehealth visit.
I would like to second that.
Can I have one more thing? I would put the same language as we put in the first thing, except in extenuating circumstances. Because again, I personally don't think Dr. Bechtel, who was doing that patient a service, should be held to the same standard of care, knowing that that patient would be better served coming in if they could, but they couldn't. So I think if there's an extenuating circumstance surrounding that telehealth visit versus just a convenience factor, and I don't know how to put that in language, and I'll let you put that in language, but I think that should be part of this. Because I do think there should be immunity for people who are doing somebody a service by allowing them to not come in.
I think that's right. I think it would be nice to have language that allows flexibility in certain circumstances like that. I think, again, just sort of looking through my field about people with agoraphobia, there are people who are scared to death to leave their homes. And it would be dramatically beneficial if I can sit and talk to them over video as opposed to them trying to get, to a doctor's office, to my office. A situation like that, I just could see a lot of people getting a lot of care that otherwise would not. They can't get to the doctor in the first place.
All right.
So do we want to vote on that motion?
Aye.
Any opposed? Okay.
All right, great.
Number 3.
So I think we're on to question number 3, and the question here is: should these standard of care requirements come through rule, as you see drafted in your statutory draft, or do we want these written protocols to be laid out in statute, as was done for the telehealth? Do you have a preference for rule or statute?
I prefer rule.
Me too.
Easier to change. Yeah, easier to change if there's new information.
Yep.
My only question about that is rulemaking process is what, about a year, Kim? And so if the statute goes into effect, what happens during that year?
Good question. That's a very good question. It is taking us at least a year to get things through.
So the rulemaking process gives us flexibility, right, with the language. Is there an advantage to having it in statute?
I think Dr. Feibel's point is that we'll have that, not for maybe the ongoing, but we'll have that gap of time where the statute becomes enacted for us to do this, but then we have that big gap of time waiting for the telehealth.
Right. I guess that's my point, though. In other words, is that the advantage that we're talking about, or are there other advantages as well?
Well, I think we always, just as staff, sorry, Kim and Nate, you guys can speak up here, but it's always more advantageous as staff to have the flexibility of rulemaking. It's particularly in situations with pandemics. And even if it, normal process is a year, you do have the ability for emergency rules. And we just, I think we saw that enough in the pandemic where there were circumstances in our statutes where we thought we could be a little more nimble if things were in rule. But there is going to be a gap of time before we get those rules live.
Well,
Even the stated advantage of time, I'm not sure is an advantage with statute either, because I don't know how long it takes a bill to become a law, but I presume it's a long time, and it may even be longer than a year in some cases for certain things if we had to change or adapt. So I like the concept of a rule as well.
I was just curious that the dentists, in other words, I agree with what everybody's saying, and that made me curious as to why the dentists wanted it in statute. In other words, they have rulemaking authority. Why didn't they? I'm just curious why they would not have thought the same thing.
So the way the tele-dentistry amendment was, they laid out quite a few requirements for dentists to be able to have as a written protocol that they would have to have either written or in an electronic form. And they did save themselves also a little rulemaking power too. But the main thrust of their I guess and this is, I believe your fourth attachment, the main thrust of their regulating was the giving all the requirements that an individual dentist would have to have in a written protocol, which, doesn't give you the same flexibility that the rulemaking authority gives you. You might be at a disadvantage in the first 6 to 12 months, but thereafter you have a lot more freedom to change and adapt to changing circumstances. And you have to look at your rules every 5 years, if not more frequently, to adapt to unintended consequences, perhaps, too. So,
yeah, I think once the rules are in place, it's a definitely more nimble process. I'm not sure I understand what happens the first year when the legislation is done. We then have to make a rule. What happens that first year? What regulates this statute at that point?
I think oftentimes you will have at least 90 days too.
And to that point, how does this statute affect our telemedicine rule that we have in place now? I mean, would that rule still exist, or does it evaporate?
So that's part of our questions is how would we, question number 6, how would the board's existing rules be incorporated into any kind of telehealth legislation? And so on the draft of the standard language under D2A, so again on page 5 of your PDF, services delivered by healthcare professionals licensed by the medical board through use of teleservice shall be consistent with the standard of care, and then under B, comply with the requirements of Chapter 4731 of the revised code and rules of the medical board. So that 2B part is tying it into the requirements of our laws and rules. We may also, in looking at the other professions that are permitted by this proposed legislation to do it, that being PAs and dietitians, we may also need to add a couple more numbers in there as well, depending on what are in those chapters and rules as well. So
yeah, and I guess my question was more to see if there was opportunities there to satisfy Dr. Feibel's very legitimate concern about that time gap
Nate,
in terms of rules we have in place.
Nate, could we draft in such a way that we allow our current rules to continue until new rules are adopted under the statutory section?
yeah, I think we could.
We would at least have the net of the rules that we have today. And if some of this is ongoing during the pandemic, we have some of those requirements suspended today because of the pandemic. So that might actually kind of cut into that 12-month time period. We might be looking at more of a, 4 or 5 month time period by the time we come through this.
True. The other thing is things that where there's a conflict, between the statute and the rule, you're going to have to follow the statute. But on the other things, you could just follow the rule, and that could give you some of those guardrails.
So I was just going to say, don't our rules continue until we take action to, discontinue them in any case, right? In other words, theoretically, those rules we have stay in place unless we modify them.
Right, unless there's a conflict. So if there's a direct conflict in the statute, then you have to follow the statute.
But won't that be true even if we put language? In other words, would our language that would allow us to continue to use our rules then supersede that statute that contradicts that rule?
I don't know. I've never actually seen anything that looks like that.
Yeah.
It's a little tricky.
The other part too, and is we're going to have likely this wouldn't be passed as emergency legislation. So you're going to have at least 90 days. I don't know that there'd be any appetite for this, but another solution is to have a delayed enactment, similar to that consolidation bill that took place quite a few months after it was actually signed into law. That could buy you some time.
I think that the legislature is going to try to enact this as quickly as possible. There's a huge appetite for telemedicine, and I think that might hinder our amendments if we suggest that. So I think we have to. It sounds like to me we have to take our chances and try to make a rule as quickly as possible and incorporate our current rule that doesn't violate as much of it that doesn't violate the statute as we can for the time being. That's my take on it. Anyone have any different thoughts?
I think that's reasonable. Yeah.
Yep.
Mr. Chairman.
Yep. Sorry.
If I may, and I'm embarrassed and I apologize, but I have an 8 p.m. TV interview. I'm going to have to excuse myself. I have to jump on an NBC interview to do. So I apologize, but I'll follow up with you, Stephanie, in a little bit. Okay.
Yeah, that sounds good. Good luck.
Thank you.
Thanks.
Okay, number 5. No. Did we talk about? We've kind of talked about that, haven't we?
Well, we talked about number 4 was what parts of the healthcare professional patient interaction should be prescribed by statute or rule. And I would wonder if we'll land in the same spot on this discussion with the preference for rulemaking authority on this.
Right?
I think so.
I guess in D1, basically, the question is, do you feel like D1 and all its subsection covers the field of the kinds of topics that you would want rulemaking authority on, setting the standard of care for the health professional patient interaction? Is there things that are too prescriptive on the one hand, or are there things that are missing on the other hand?
I'm looking through it.
I thought it was pretty good. I did have a question, Nate. Hopefully it's not too granular of a question, but when I look at D1A, where it says methods to ensure that patients are fully informed, the word fully got my attention, because I think if we're going to use the word fully, then we sort of have to define that, because otherwise it's a very sort of objective, standard as to when somebody is fully informed as opposed to just informed.
Yeah, I think that's a good point. I believe that I took that language from the teledentistry provision, so I certainly would be, if you all believe that fully is sort of a little bit too much, we could just keep it to informed and scratch fully.
Agree. Yeah, I think that's a good idea and a nice catch, Dr. Schottenstein.
Thanks.
Okay, should we move on?
That's right. Yes. Question number 5. So this question is how do we account for our differences in specialties or professions when we're looking at those standard of care requirements? Now, I think this is really a rule question. If we go with the intent of having that all done in rules, so I don't think we need to get this right for the statute. But I do think when we go to talk with members of the legislature, they're probably going to be curious as to what if we're asking for this rulemaking authority, they're going to want to know, well, what kind of things would you be putting in your rule? And so I think this question falls kind of in that bucket where we're asking, do those differences, do we account for those differences in rule and kind of what do they look like?
I think if we put differences in this, it's going to be more specialty specific than regarding MD, DO versus DPM. In other words, I think each specialty is going to have their own different standard of care requirements. If we get down to that level of granular detail on the rule, I don't know if we will. But this is a pretty loaded question. It's going to take a long time to hammer this out because I don't know how specific the guardrails we want on this are. Anyone else?
I think historically that has been the issue that has been the most difficult. And that's why we've generally landed at very broad language about appropriate for the condition, appropriate for the patient. And then you try to find the things that are more universal and include those like record keeping and, making sure that the patient's informed and, those types of things. But I think it's easy maybe to say the outliers, like, you probably are not going to be able to do surgery without examining the patient and being there in person or do a procedure. But there's a lot of other things that, get a lot more difficult to define. So I think we'd want to look and see if any other states have done that or, other things, because I think that gets really, really tricky.
I would agree with that.
Yeah, even if you look at the FAQs that we have around 4731 1109, there's 23 separate FAQs interpreting that, and a lot of them deal with specific practice type situations that are outliers, like some psychiatry outliers, some colonoscopy types of prescribing outliers, and those come from real life questions that we get when the rule goes into effect. So,
Great. Anyone else have anything else on that? Okay, let's move on to number 6.
And this question is relative to how our current rules, our existing rules, how we should incorporate those into the legislation, or or account for those as current rules and keep them in rule. Thoughts on the current rules that we have.
So I was hoping that some current rules would provide some guardrails. As you can tell in the first part of the discussion, I was, pretty liberal with my approach to telemedicine. But part of it, I was just thinking, for pain physicians, we have such good guidelines, rules, and guidance. So I really wasn't worried, about my own specialty, and was, at that point advocating for citizens to get access to other things. In the absence of having the rules that we have, I'd be very uncomfortable with telemedicine and pain management, considering what's happened before in our state with excessive prescribing. So I would hope that we'd be able to maintain those.
Yeah, I mean, I would echo that. I think that, part of what gave me comfort also for advocating a more sort of liberal expansion of telemedicine was knowing that we have these, what I consider, guardrails in place for these specific areas of the practice of medicine. And when we talk about the abuse of telemedicine, these are, the areas that would most worry me. And I feel like, again, my thought was if we were inclined to expand the ability to have telemedicine, that these would be some of the, minimum standards kinds of rules that would keep things, healthy for our profession.
I agree with Dr. Sloan and Dr. Johnson on this.
Okay, sounds like you have consensus.
Yeah, one thing we really could do too is, the current rule that we have deals only with that initial visit when there's prescribing. And so, the rules that you would have under the statute would be broader and would deal with telemedicine if it was the second or fifth or 12th visit. And that might be, I think that's something where we've probably had a gap.
Okay, I think our last question then is really about the technology again, and getting back to the audio and the video, and should these services be allowed to be provided asynchronous, how do you say that right? Asynchronous technology that don't have both the audio and the video. In other words, what about delivery through telephone and emails?
So I definitely have an opinion on this, and I know others may disagree, but when it comes to telemedicine, I really believe in the audio-visual synchronous interface. I do understand that there are situations where people don't have a smartphone or don't have access to something, but I'd also like to point out that there are separate rules and billing codes and CPT codes for Medicare for a telephone visit. Because then if you allow a phone, basically I could never have my MA, call patients back for little things. I would just call and bill for a visit every single time. I just first have concerns about that. So I support the synchronous audio-visual, and physicians and patients can still do email and telephone exchanges as currently allowed under the
I would agree with all Dr. Swain said.
In that emergency Medicaid rule, that's your last attachment, where they're defining what telehealth is. This would be on page 48 of your PDF. I think they have a nice, description of, I believe, what we're all talking about, which is via synchronous, interactive, real-time electronic communication comprising both audio and video elements. So some kind of language similar to that would be what I'm hearing everyone is in favor of.
Well, if I may, I just would like to clarify. So to Dr. Sohn's point, there are these CPT codes for a phone consultation. So don't we, on some level, already have the ability for doctors to consult with patients over the phone and bill for it?
Yeah, we do. I will say that, at least in my experience, I have no insurance contracts will actually pay those particular codes, although those codes do exist. But they could certainly do it. And I would hope that if someone wanted to use a telephone visit just because of an extenuating circumstance, that that would be a rare situation. I suppose you could also make a claim that if there was some sort of extenuating circumstance, like lack of access to video, but only in those instances could you have a phone visit or something. But the issue with that is Medicare has been clear on their guidance, even in the pandemic, that it has to be a video interface. In terms of what you bill for codes similar to how you do it in office. And if you don't have a video and you use a telephone, you can still bill for it. And Medicare is actually paying during the pandemic, but it's at a different rate. It's at a lower rate.
Gotcha.
And it also means you haven't seen the patient within 7 days, and you're not going to see the patient again within the next day. As well, to get paid for that code. And this if Ohio allows this might change that and allow those people to at least bill private insurance potentially based on the telehealth visit and the telehealth code, because we're talking about telehealth here. And I think we should keep that as video and audio synchronous.
So I guess I wonder if it's possible to, as in the same way that we've talked about having language that allows for extenuating circumstances, to do that with regard to the phone as well, because there are people who don't have Wi-Fi or good internet, or patients with body image issues. I've got patients with anxiety issues. They don't want to be on the video, but they're comfortable, talking to me on the phone. And so, I wonder, and again, there's an expense too. I think that a lot of people maybe who would afford a phone maybe don't, afford the computers, the laptops, the iPads, or the smart technology. And so I just wonder if it's possible to have language that allows for, an exception if there's, an extenuating circumstance that could be documented in some way.
Yeah, I'm not against that, because I would assume those extenuated circumstances as a rationale why.
I think one of the things, again, we need to consider when you look at the Ohio population, how many 80-year-olds and 90-year-olds have smartphones with cameras? Not many. And my experience has been with video visits, a lot of times you attempt those video visits, try everything you can. The office personnel calls them in advance, instructs them exactly what they need to try and do, and they fail. They just can't figure it out. So, we just need to be a little bit careful that we don't exclude access to telemedicine to 80-year-olds and 90-year-olds because they don't have the technology to be able to deal with that. I would be very opposed to using like telephone visits for the initial visit. I think that would be challenging, but if you have a good relationship with a patient and they're able to question about a medical problem and they're unable in any circumstance to do a video visit,
Perfect. I mean, we've seen it even on our meeting tonight, sometimes when the camera would freeze up and such, and sometimes, the video is just not working out for the appointment, and you have to just sort of pick up the phone to finish the appointment.
Yeah, that's true. And it was happening to me where I was slowing down, and I found if I shut off my video, I could hear everyone without any skipping, which is why you may have seen me disappear and reappear and stuff like that. But I wonder if there's a way that it could be written such that you could preserve all of those things. So, our intention is audiovisual interface. You have to make a good faith attempt or whatever legalese you need. And if that fails and it's an extenuated circumstance, then maybe.
Just a second. Can I ask you to pause for just a second? I don't know if it's because you were talking about video quality, but ours just dropped down on the live stream as you were discussing that. So if you can hold on just 1 second, I'm going to make sure that it's okay for us.
Gremlins.
Somebody was listening to our conversation.
Yeah, or they're wanting to prove Dr. Bechtel's point. So There you go.
And now that we have ended that conversation, the video stream has resumed. So you're welcome to go ahead. The stream quality is back up to good health. Thank you.
Extremely helpful. And I think unless anybody has anything further that
I have one more quick question. I'm sorry, real quick.
Sure.
It's on page 7 of my PDF. My PDF has been different than everyone else's, but I think it's on page 7, and it's at the bottom of. I got to figure out what section it is. It's number 2 next to. I don't know which section it is. I'm sorry. It says a healthcare professional may negotiate with a health plan issuer to establish a reimbursement rate for fees associated with the administrative costs incurred in providing telehealth services, as long as a patient is not responsible for any portion of the fee.
Mhm.
I think that's a dangerous thing to put in a statute, because this will encourage telehealth for sure, because they are going to be responsible for a portion of the fee. Unless I'm reading this wrong, maybe I'm reading it wrong. Maybe is this just for something other than the office visit fee? Does anyone know?
Yeah, I don't know, but listening to you read it makes me concerned as well. And I understand your point. Yeah.
And then the next line says, healthcare professional providing services shall obtain a patient's consent once before billing for the cost of providing the services. I don't know what that means either.
The way I read it was, as opposed to having to get consent every time, like multiple times.
But why do we need to get consent for billing a service that we've given them informed consent that we're doing the service for them? I mean, I think that's. I mean, how do you get consent that you're going to bill for the service? What do you say? I just want you to know I'm going to bill for this service before we start. I just think those provisions, I don't understand them.
Yeah, and there's one that I don't understand as well. If it's okay, I'll just sort of jump in with it, which is there's something in there about, and it's not. I don't see it here in this memo, but in the sub bill, there's something about needing to verify the patient by asking for a name and a password or a personal ID number. Do you all have a recollection as to what I'm referencing?
Yeah, I saw that too. I didn't understand what that meant either.
Because I'm sitting there thinking, so I'm going to ask my patient of 20 years for a password. You know, it's just I wasn't sure really what the intent of that was.
I think initially, I think these are questions that are all great questions that we're going to have to get back to you on. I think the initial focus of today's draft and sort of our first discussion, Stephanie can step in here if you'd like, but I think we envisioned, you know, at least a couple meetings of the ad hoc committee meeting, and that the theme of today's was to deal with kind of the standard of care provisions, and that some of these others are dealing with some of the billing and maybe some of the technology stuff that maybe we would cover in a subsequent meeting. Is that correct? Or
that's great. That's great. I didn't
I
realize.
think that's right. Yeah, and I think that we can do a little more research about those questions. So I think great. So that initial ask of that client identification piece is something we can look into a little bit more for the next discussion, as well as trying to understand the intent behind the billing piece. And I think what will be important for us to remember is that this has already left the House. And so this is their language already, and so we'll be talking to the Senate about this. So some of these, you know, adding in our language is probably, I mean, it might be a challenge, but it might be a little less of a challenge than some of the existing language as it is. So, you know, we'll kind of get the lay of the land of really who drove that billing language and why, and certainly offer our input and advice on that. We're not going to shy away from opining as to that, but I do just want to be realistic about expectations about the language that's already in there.
That's great. All right, I think then we can, if everyone's okay, we can, unless anyone has anything else, motion for adjournment.
So moved.
Second.
All in favor?
Aye. Aye.
Opposed? Same sign. Thank you so much. Thank you, everyone, for staying on for so long. Sorry it took a little longer than we expected, and thank you to the staff for such a good job with the presentation. We appreciate it.
Thank you guys so much. This is extremely
Thank you,
helpful for
everyone.
us.
Yeah. Good
Very
night.
helpful.
Bye-bye.
Bye-bye.